Good morning. Welcome to our webinar, Updates on Aplastic Anemia and PNH from the American Society of Hematology 2021 meeting and from the ASCO and EHA 2022 meetings. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible that during the program, you can lose your internet connection. If you do lose connection to the online program, you are able to log in and hear the audio portion using the call-in number in your reminder email. The program today will be archived to our website within just a few business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window, and when you're done typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your healthcare. Our specialist today is Dr. Phillip Scheinberg, and Dr. Scheinberg actually recorded his presentation in advance for us. But he will be coming on live towards the end of the presentation to be able to answer all of your questions. So we're going to go ahead and play the video with Dr. Scheinberg in his presentation. And like I said, he'll be joining us a little later during the presentation to be here to answer all of your questions live.
Hello, my name is Phillip Scheinberg. I am a hematologist here in Sao Paulo, Brazil, but I did my training in the United States, internal medicine, hematology, oncology, and spent many, many years doing research at the NIH, both at the clinical level and at the laboratory level. And I am a big fan of the foundation, the AAMDS Foundation. I've been involved for many, many years in different capacities, and it's a pleasure always to speak to you about new stuff, new data, perspectives, and how things are changing. So what we will be doing today is talking a little bit about what has been presented in the major medical meetings. We usually have two major hematology meetings that are focused on hematology, that are ASH, which is the American Society of Hematology, and then the European Hematology Association, which is the European meeting. And then we have ASCO. ASCO is more focused in oncology, so there's very little, if anything, in marrow failures or aplastic anemia in general. But I will be focusing more so on the other two meetings. So with that, let me get my pointer going so I can show you some. Okay. All right. So aplastic anemia or severe aplastic anemia can be treated with bone marrow transplantation or immunosuppressive therapy. Bone marrow transplantation was started first, like in the 70s, late 70s, early 80s, for this disease. And immunosuppressive therapy came later, in the 80s and 90s. So Today, we have two major forms of treating patients who are diagnosed with severe aplastic anemia. If somebody is less than 40 years of age and has an HLA-matched sibling donor, meaning that their HLA are identical, then transplant is usually the preferred treatment of choice. If somebody's older than 40, or if they don't have an HLA identical sibling donor, then immunosuppression is the preferred treatment of choice. So the paradigm has been holding for decades now, and we're still using that paradigm today. Now, we're hoping to change that because there's been a lot more data that we have learned over the years. So I'm not going to be talking much about transplantation because at these meetings, usually there's not a lot of transplantation. The focus is more on drugs, therapies. At ASH, there's benign hematology, there's malignant hematology, there's blood banking, but there's also a little bit of transplantation, but that's not the focus. There is the ASCO2022 or the American Society of Bone Marrow Transplant, which now has changed their name. The cellular therapy focuses more on the transplantation aspects of all diseases in hematology, including aplastic anemia. And so we'll be talking about the medical management more so than the transplant management. So the paradigm is ATG for the medical management of severe aplastic anemia in patients who are diagnosed with this entity. Now remember that this is a diagnosis of exclusion, meaning that you have to exclude other conditions or diseases that could mimic aplastic anemia or severe aplastic anemia. Now, the severe and non-severe is based on how low the blood counts are. So if the neutrophil count is less than 500, platelet count less than 20, or reticulocyte count less than 60,000, two of these three make up for severe aplastic anemia. The non-severe or moderates are treated and approached a little bit differently. There's not a lot that came out of these meetings in the last 1 or 2 years in the area of the non-severe aplastic anemia, but there's more so in the severe space. So immunosuppressive therapy, as I mentioned, is with ATG, which is anti-thymocyte globulin. And that's basically what this is. It's globulin, which is another name for antibodies, which are targeted against the thymocytes. So thymocytes are actually cells that are present in our thymus. And we're born with this. This is part of our immune system. It's where T cells become adult or mature. But in certain scenarios, this organ has to be removed from children due to other medical conditions, usually involving the heart and the lungs or both. And so you have a tissue that is very rich on T cells. And these T cells then are then given to an animal, usually a horse or a rabbit. And that's why we have horse ATG or rabbit ATG. And these animals will form a lot of antibodies that are targeting the human T cell. This is a human T cell that has a lot of antibodies that are recognizing it. So then this multitude of antibodies are then purified, and then they are tested and then given to the patient. So the immune system is attacking the bone marrow, so we attack the immune system, right, to reverse this problem. I'm mentioning this because there are some abstracts that are looking at ATG and horse and rabbit ATG on the abstracts that were presented at this meeting, at these meetings that I just mentioned to you. So I thought I would just give a very brief presentation of what we are talking about instead of just saying, this ATG, that ATG, when I talk a little bit about the abstracts. This causes T cells to become depleted when you give this to patients or humans. Now, remember that this is an animal serum. It's a foreign protein that are antibodies. This is not human antibodies. These are a horse or a rabbit antibody. that does recognize lymphocytes or T cells, and you give this to humans, and you can see here, this is the level of lymphocytes, like 1500. And you can see that with horse ATG, it goes down like the next day. And then it kind of goes up very quickly with horse ATG. You can see that after 2 weeks, the recovery of lymphocytes or T cells, which are part of the lymphocytes, is very quick. Now compare that to rapid ATG, where it goes down just as it goes down with horse ATG, but it stays lower for longer. So this is a more immunosuppressive drug, a rapid ATG, than horse ATG. Although in clinical trials it did not show superiority, we did a trial where we were testing if rapid would be superior to horse based on this dynamics that I'm just showing you. And that was not the case, actually. It was the contrary, where rapid ATG was less inferior. Didn't go well, right? It was less effective or inferior. I'm sorry for that English. Than horse ATG. So horse ATG actually did better. Why? Because the response rate to the horse serum or horse ATG plus cyclosporin was better. And there's a very powerful correlation between response to immunosuppression and survival in this disease. So you want to respond. If you respond to IST or immunosuppressive therapy, you put yourself in a better category. So this is about the anti-thymus cyclosporin. Now, here are where the more recent advances have come from. So I talked about the backbone, ATG plus cyclosporin, preferentially horse ATG. The problem is that horse ATG is usually not widely available outside of the United States. That might change. We're having meetings with companies to discuss this scenario to see if that can be changed. So outside the United States, horse ATG is far more scarce than rapid ATG. So rapid ATG is more widely available, but it's not the best ATG for patients with severe aplastic anemia. This is given alongside the one. So there will be abstracts talking about the ATGs, and there will be abstracts talking about the thrombopoietin receptor agonists. Now, this is a class of drugs. So I'm doing this for the purpose of just presenting to you some of these players. So when we discuss these abstracts, you'll understand what I'm talking about. So this is a class of drugs that were not developed for aplastic anemia. They were developed for a disease called ITP that some of you might be familiar with, which is immune thrombocytopenia, and they do stimulate the megakaryocytes. So megakaryocytes are cells that are present in the bone marrow that produces platelets. So since ITP, the platelets are low, you're stimulating the cells that are producing platelets, and the platelets go up. This was approved in the United States for ITP 2008. There were two drugs at that time, Thrombopoietin and romiplicin, and there are abstracts with both that I'm going to be telling you about. So that's why I'm doing this presentation, introducing the actors, so to speak. But we then investigated this in aplastic anemia. We started this in 2009, about a year later after it was approved for ITP in the United States. And we started developing clinical trials to test mainly Thrombopoietin for aplastic anemia. And we did show activity of about 40 to 50% in refractory patients. That means patients who had failed immunosuppressive therapy as their first treatment, sometimes after the second or third treatment. And we had responses to this agent. And it was approved by the FDA in 2014 as second line. The Europeans, the year later, approved it in second line as well. And then we ran a study which started in 2010. We wrote that in combination with IST or immunosuppressive therapy, which was horse ATG cyclosporin, plus Thrombopoietin. So that's two drugs that are stimulating the bone marrow, and two drugs that are immunosuppressive, and one drug that's stimulating the bone marrow given in combination. And this came after a lot of negative trials, which have tested horse ATG plus mycophenolate, which didn't do much in terms of response rates or preventing relapses. We treated over 100 patients. Even rapamycin or sirolimus, which is another immunosuppressant, really didn't give us better results than horse ATG alone when given in combination with horse ATG cyclosporin. We even tested alemtuzumab or Campath, again, did not show response rates. We even did rapid ATG compared to horse ATG, and again, we couldn't beat horse ATG. So the advance actually came from not giving more immunosuppression, because all these drugs I mentioned to you are immunosuppressants in combination or in place of horse ATG, and all these trials were basically negative. So that was pretty much 10 years of my career. In any event, what showed results was adding a drug that stimulated the bone marrow with immunosuppression to see if you could improve outcomes, and it worked in second line and in the front line. So the Thrombopoietin acts on the receptor that we call it. So that's how the interior of the cell communicates with the exterior of the cell, because there's this membrane, right? There's this thing called the cell membrane. So the inside actually doesn't see what's happening in the outside, but it's through these receptors, that this conduit, that the cell knows what's going on the outside. So the Thrombopoietin molecule hits the receptor of the thrombopoietin, and romipilstin, which is the other agonist in this class, actually hits the same receptor, but up here. So they are stimulating the thrombopoietin receptor, and thrombopoietin, as I mentioned to you, are stimulating the megakaryocytes, but we've learned also that they also stimulate the stem cells. And since aplastic anemia or severe aplastic anemia is a stem cell deficient disease, meaning that the stem cells are attacked by the immune system and they disappear, anything you can do to try to stimulate them back would theoretically be beneficial. The problem is that the immune system is attacking the stem cells. So just stimulating the stem cells would not be enough. So you have to kind of control this attack with the immunosuppression that I mentioned to you, or ATG cyclosporin, and then stimulate these stem cells. And that combination is what really yielded better results. So now I'm going to go to the abstracts. So now that I have introduced you the actors and the main players and how things evolved very briefly over the years. So the one things we saw at EHA, which is the European Hematology Association meeting this year, was that Thrombopoietin was then tested now in different ethnic populations. So when these studies were done initially, the pivotal studies that I briefly discussed with you, they were mainly done in the West. So what we saw at EHA is that there were reports of Thrombopoietin given as salvage therapy in second line in patients, for example, in Asian countries, obviously of different ethnicities, different Asian countries, confirming that the drug or the agent was effective in this scenario of refractory or patients who were unresponsive to initial therapy. So that was reassuring, indicating that Thrombopoietin was effective in an Asian population, for example. Now, just keep in mind that for Thrombopoietin, the dose has to be cut in half. In the West, we went up to 150 milligrams of Thrombopoietin, which is higher than what's usually used for ITP, and because we really wanted to hit that progenitor stem cell to stimulate that cell. So that's why we went higher dose up to 150 milligrams. But because of population pharmacokinetics, the dose in the East or Southeast Asia is half. So that was one of the abstracts I wanted to bring out. I thought it would be better for me just to kind of present you what the topics instead of just going through the abstracts, because there's a lot of text, a lot of data, and it gets very complicated to show, and it gets very busy. So I opted for a cleaner presentation, and I just told you what's in the abstract, so you don't have to read it. Now, the other area that was explored at EHA was the duration. So when we started investigating this agent, we gave it for 6 months, and then we tapered or we stopped or did a very quick taper. And we thought that 6 months would be ideal. We did initially do the initial trials were 3 to 4 months, and then there was a follow-up study in the United States that extended that to 6 months, and 6 months appeared to be better than 3 or 4 months, because some patients who did not respond to ultrahomopathic by 3 months, they responded by 6. So 6 actually became more ideal. Now, there were some abstracts at EHA suggesting that probably extending for 12 months might be better than 6 months, because you tend to see patients who continue to respond at later time points. So that was one interesting observation that was presented in the form of an abstract at the European meeting. Another topic of presentation and discussion was that the combination of ultrahomopathic with immunosuppression has been shown to be very effective in adults, and a subgroup analysis by the American trial that was conducted in the NIH did not seem to show that the combination of ultrahomopathic plus IST or immunosuppressive therapy with horse ATG cyclosporin was in fact as effective in children in a pediatric population. Now, remember that children already with horse ATG cyclosporin alone, they do better than adults. So there's a very strong inverse correlation, meaning the younger you are, the better. The older you are, the response rates gets lower. Overall, the response rate to horse ATG is about 60 to 65%, 2/3. With the addition of ultrahomopathic, it went up to 80, 85%. But specifically, the complete response, meaning that those responses that brought the counts closer to normal, was much higher when you added ultrahomopathic to immunosuppressive therapy. Now, that was more noticeable in the adults. In the American subset analysis, children didn't really show that effectiveness. But there are reports coming from Asia suggesting that maybe in a different population, that there might be a benefit of adding ultrahomopathic to immunosuppressive therapy. Now, this is, a retrospective study. This is not a prospective large trial. There's no randomization. So these are just observations. So we have to take these with a grain of salt. But I thought that was interesting. And the other abstract that was presented by the Japanese actually was the combination of not horse ATG with cyclosporin ultrahomopathic, but rabbit ATG with cyclosporin and romipustin. So that's why I introduced you these actors, so you were more familiar with what I was going to talk about in these abstracts. And they show that based to their historical experience, that the rabbit ATG cyclosporin romipustin was better than rabbit ATG cyclosporin. So why are they using rabbit ATG cyclosporin? Because there is no horse ATG in many countries, as I mentioned, including Japan. And there's also a sense that the inferiority of rabbit ATG might not be as pronounced in Asian countries, for example, as we have seen in the West. Now, there are large meta-analyses, several prospective and retrospective studies, and including meta-analyses where they lump a lot of patients from different studies, concatenating over 1,600 patients, again, confirming that horse ATG is a better formulation. But in this Japanese study, which presented this year, they compared this triple regimen with their historical rapid cyclosporin, and they showed that it was better. Now, there are prospective trials also in this space that are ongoing to do it more with a more rigorous design and statistics. And there are also some reports, but these I call them anecdotal because there were 4 patients who either got COVID and then developed aplastic anemia, or they were vaccinated for COVID and then they developed aplastic anemia a few weeks later. Again, the numbers are very small. We have 4 patients here, 3 patients there, 6 patients there. And it's hard to prove that there's a cause and effect. I mean, there seems to be an association, but it's hard to know actually if that vaccine or if that infection was actually causing the aplastic anemia, because we do see patients who develop aplastic anemia. No, it's rare, but it happens. And again, these studies are just observations, and there's very little in the way of rigorous statistics, and it's all using indirect comparisons. So it's hard to know if there's something there. We have seen it here, and again, don't know 100% if there was a positive effect. We have treated these patients as we treat patients with aplastic anemia with immunosuppression with a L-Thrombopac, which is the only agent that is approved in second line and in first line. In aplastic anemia, although there is data on rompicin, it does not have approval in the United States. And in many countries, it's not approved there, but L-Thrombopac is. So again, I just put it here because there were reports in the form of abstract, saying that, look, this is what we saw. We don't know if there's something here, but we're reporting it. So that's why I included the COVID here. Now, this did not come from EHA this year. It came from EHA last year, 2021. But the reason I included here, this is presented by Marisha Patel, the long-term follow-up of the horse ATG cyclosporin L-Thrombopac study that led to the FDA approval in 2018, showing that after a median follow-up, like a 4-year follow-up, in the initial report after a follow-up of about 18 months, the survival was north of 96, 97%. Now with longer follow-up, the survival of those patients who were treated many, many years ago, still very favorable, still over 90%. So this is important information that came out of EHA last year. But I highlighted here because it's very relevant and important. And if you are a partial or a complete responder, your chances of being alive, it's probably even better. I mean, 91% is pretty good, but now you're talking about 95%. So responding to ACE or ATG cyclosporin L-Thrombopac, ACE, if you respond long term, your prospects are very, very favorable. Again, this is from last year, but I thought it was important to include for you just to you have that information. Now let's go to ASH. We'll have ASH in a couple of weeks in December in New Orleans. So I'm bringing ASH 2021. And here, some abstracts that looked at combination of immunosuppressive therapy or IST with L-Thrombopac, but not in first line, but as salvage. So these are patients who were treated initially with immunosuppression, usually with ATG cyclosporin alone, and they relapsed, for example, and then you try to salvage them. You try to do another course of immunosuppression. And this is retrospective historical results, but it appears based on this presentation or this abstract is that where we used to give just immunosuppression alone, give another round of ATG cyclosporin, for example. Somebody got course ATG cyclosporin, they didn't respond or relapsed. We gave them rapid ATG cyclosporin. We have several publications in that regards, and the other way around as well. They started with rapid ATG, given a second course with horse ATG to try to rescue their marrow function. But there's a report that if you do that and add L-Thrombopac, doing indirect comparison with historical controls, it's better than just giving immunosuppression alone. So I thought that was interesting because this is a question I'm asked when I give a lot of talks around the world about this. Should we just give another course of immunosuppression if they not get Thrombopoietin initially with their first round? Is it better to add Thrombopoietin in the second round? And based on this report, yes, it appears it's beneficial to do that. Now again, retrospective, looking back, historical data. So I thought I would bring that to you. The other important aspect that was brought that I wanted to bring out to you was clonal evolution. So clonal evolution happens about 10% to 15% of patients when they start with aplastic anemia, and over the years, over time, they can acquire cytogenetic abnormalities. And those can be of high risk and of low risk. High risk is when you have usually chromosome 7 involved, a lot of abnormalities in your cytogenetics, a lot of dysplasia in the bone marrow, a lot of aspects of myelodysplasia with decrease in blast. So we call those high risk. Low risk is everything else. But there's an NIH analysis which looked at hundreds of patients and found out that higher age and higher neutrophil count actually at baseline actually were predictive of those who would have clonal evolution over time to high risk of clonal evolution. We have looked at different aspects of biology and trying to predict this, looking at telomere lengths, and we have shown an association. This is not presented at ASH, but this is presented publications from years ago, showing that patients who had very short telomeres at baseline had a higher chance of having clonal evolution. Or even nowadays, looking at mutation, a lot of genes being tested and mutations and panels and exomes and large sequencing. This has been looked at as well, but it doesn't seem to correlate well with predicting those patients who with time will develop high risk clonal evolution to myelodysplastic syndrome, and sometimes in a few cases even leukemia. So I wanted to highlight that as well. Another abstract that I thought was very interesting was a collaboration between the NIH and CIBMTR. CIBMTR is the registry for bone marrow transplantation, Center for International Bone Marrow Transplantation Registry, and they sequenced a lot of patients, hundreds of patients, 700 or 800 patients who actually went to transplant for aplastic anemia. And one interesting observation that came out from this study was that if this is all done retrospective, right? Because patients had already been transplanted. The sequencing happened later, so they did a lot of sequencing, genetic sequencing, and they found out that in patients who it was identified that they had a genetic mutation that was associated with hereditary forms of aplastic anemia, actually did worse after transplantation. They died more. So this was not something that was recognized by the physicians or the transplanter at the time, because this is not standard of care to keep doing these sequencing, and plus we don't know how to interpret them. So we don't have the knowledge at this point to know if they change, or should we change the decision making based on them at all. So this study actually raises the question that maybe we possibly should be looking at these, and maybe thinking about these, because they were unrecognized inherited subsets, meaning that at the time they were unrecognized because the sequencing wasn't done. But what the data showed was that in retrospect, those patients who had mutations that are associated with constitutional or hereditary forms of marrow failure, and there's some genes that are associated with that, that were identified, and then they see how the patients went. They didn't do as well as those patients who did not have these mutations. So this is a very robust analysis. It's been very big, a very good collaboration between these two major institutions. And I thought that data was very, very interesting, especially because at the time that this was presented, I had a patient who didn't do well with transplantation for aplastic anemia, a very young gentleman. And we learned months later that he had a unrecognized inherited subset. And I was very sensitive to this at the time because that really touched me a lot. That the patient should have done well, but then when this data came out, it was like, oh, so he was one of those, and he had several complications after transplantation. So I thought this was very important data. And the other abstract I wanted to point out to you is this is our trial. Actually, we designed this trial years ago, and it included 54 patients. May 30, I think, was May 2020 was last patient was included, which is L-Tropopag and cyclosporin as first-line therapy without ATG. This is called the SOAR trial. This has been going on for a number of years now. It completed, and we're analyzing the data now, and it shows that L-Tropopag, which is oral, and cyclosporin, which is oral, is effective. About 45 to 50% response rate, by 6 months in terms of blood counts. Now, this is appealing, especially when ATG, ATG has its toxicities as well. You have to admit the patient, put in the catheter line. We have to monitor them. You have infusion reactions, serum sickness. In older patients, it can be hard to give because of the reaction that you can get. Remember, these are animal proteins. And so you have to be in a center to have some level of expertise. So we developed this trial to see if the results without ATG would actually be comparable to those that include ATG. So they're not as good as those regimens that include horse ATG, cyclosporin, L-Tropopag, but in centers or places, and I visit many countries and give talks all over the world, they're very vast, and they don't have access to a horse ATG, for example, or it takes a long time for them to get to a center to start any form of therapy. And this was appealing because you can start the next day without having, you can do this as an outpatient. You can do the bone marrow, do the cytogenetics, do everything you have to do to work these patients up, and then you can start treatment. And there's a current NIH trial which is actually doing that. They're starting with L-Tropopag cyclosporin quickly, and if patients don't respond by 3 months, then give horse ATG. So to see if you can then rescue them with a response. So this is the largest trial, prospective trial. It's not a randomized trial, but the results were presented at EHA last year and at ASH. So I thought this was important to bring up to you because we're probably going to be publishing this paper by early next year. So I thought this was important to bring up because this was presented at ASH2021. And to finalize ASH2021, there is a very interesting abstract that includes machine learning to see if you can predict those patients who might have a genetic mutation. So obviously, to test for genetic mutations or to know that somebody has a genetic mutation, you have to test for genetic mutations. And testing everybody that comes all over the world might not be feasible due to several issues of logistical issues and costs, et cetera, access. So this is study coming from the NIH and several centers, including centers in Brazil, which looked at can we predict based on information that are more readily available those patients who might be at higher risk of having a genetic defect or mutation. And a couple 27 variables were included in. The older you are, so there were some things that are associated with that. So age was one of them. Telomere length, a shorter telomere length was another one. And some clinical variables based on early graying, a family or personal history of lung or liver disorders, fibrosis in the lung, or a family history of patients who have aplastic anemia or MPS. So some clinical variables associated with the age and telomere length actually turn out to be very predictive of those patients who might have an underlying genetic defect in one of these genes that are associated with marrow failure. Now, the telomere length part of this is not something that is widely available all over the world. So they try to take out the telomere length of the equation, and then the predictive value actually dropped, which was unfortunate because we wanted to, keep it high. But when you do include the telomere length, I mean, you're getting, 85, 90% predictive that this patient is probably going to have an underlying genetic defect, especially if their counts are not very severe. They're moderate. They've been going on for a number of years. The tumor length is short. They have early gray. They might have a family history of marrow failure or lung fibrosis, pulmonary fibrosis, or cirrhosis. Then you start getting to a point where this patient probably has something. And we do see this in our clinic. We do see a couple of aplastic anemia patients a week, and we can tell sometimes by the history and by the telomere length and the context in which this marrow failure is presenting that this patient is likely to have something. It's not 100%, but we have these clues, and I thought this was very interesting because this is AI, or artificial intelligence. Machine learning is part of artificial intelligence to try to predict those who might have an underlying genetic defect. And again, there were some abstracts, like in COVID. I'm not going to repeat what I just mentioned about the ones that were presented at EHA, but again, small numbers, trying to see if there's anything related to COVID based on getting COVID or the vaccinations for COVID. And again, we can't conclude that there's a cause and effect, other than there are associations that people are reporting in different parts of the world. And, maybe at some point, all these have to be put together and try to make a robust statistical analysis to see if there's a signal that indicates that indeed there might be more than just an association, but a cause and effect. So this is the highlights that I wanted to bring out to you. Presented on these major medical meetings. This is our group here in Brazil. This is my email. Please feel free to reach out whenever you have any questions. If you want to, I enjoy a lot trying to help patients and physicians with marrow failure syndromes in general. So here's my contact, my email, and I'd like to thank again the foundation for asking to do this. It's a great pleasure always to help and work with the AA and MDS Foundation in the field of marrow failure. So once again, thank you very much, and I will be available for your questions when we go live. So I hope I made this understandable to you.
Dr. Scheinberg, thank you so much for joining us.
My pleasure. It's a pleasure to be here.
Thank you for the wonderful presentation. And we have some great questions for you.
Okay.
Our first question is, what is the dose of eltrombopag in aplastic anemia and MDS, and how long should it be tried before deciding that it is not effective?
So eltrombopag is approved for aplastic anemia. It's not approved for MDS. So its use in MDS is off label. And there's a black warning in the package insert, given the fact that there's some cases that have been associated with progression of MDS. So for aplastic anemia, it's approved in second line and in first line. When we started the study initially, we started with a ramp up design where we started at 50 milligrams and we went up to 75, 100, 125, 150. And we incremented the dose by 25 milligrams every 2 weeks until we reached the 150 dose. And then we kept that for 3 to 4 months. And we saw the results that we saw that led to the approval for second line. But we
there was a follow-up study, which was using the eltrombopag at 150, starting from day one without the escalation, the upward escalation, and giving it for 6 months. And what was observed in this study was the fact that when you give 150 starting, which we think is the most effective dose, because when we did the initial trials, the responses were seen at the higher doses. Very, very few patients responded at the lower doses. So when you give 150 starting on day one and you give it for 6 months, the overall response rate in the second line is about 50%, but most of these responders are actually robust responders, meaning that their counts got really, really good. And this was different from the initial experience. So 150 milligrams is the dose that has been applied for the prospective frontline therapies, and giving it for 6 months because there were some patients that responded between 3 and 6 months. So 6 months is the time frame that has been incorporated for all the prospective trials when you're giving it in combination with immunosuppressive therapy, frontline as first-line therapy, and you give it for 6 months, and then if there's no response at 6 months, then it's really time to question if this is an effective strategy for this patient. So 6 months is the time frame that is usually used. 150 is the dose that's usually used, and you start it from day one and you give it for 6 months. When you do this as a salvage therapy, 6 months is rather a arbitrary time point, but it's a reasonable amount of time to see if this is going to be an effective strategy, and you may decide to continue or not depending on what the counts you're doing at that point, but you may want to think about other strategies. In the frontline trials, they all kind of stopped the drug at 3 or 6 months, and that's part of how the protocols were designed. So 150, 6 months, starting on day one, and we no longer do the dose escalation.
Thank you. Their next question is, it seems that the platelets are the last to respond to treatment. Do we know why this is, and is it just in a certain subset of patients?
That's a very interesting question because it always seemed that the platelets are lagging the other counts. The kinetics or how these counts recover when you treat them with immunosuppression, with or without eltrombopag, actually is quite variable. Some patients improve their hemoglobin first or the neutrophil count first, and the platelet kind of stays behind. But we have seen patients that the platelet count actually has gone up more quicker. But it's correct. The observation is correct. The platelets seem to be lagging the other two lineages, meaning the red cell lineage and the white cell lineage. But when eltrombopag was incorporated into frontline therapy in association with immunosuppressive therapy, horse ATG cyclosporin, it seemed that that might have changed the kinetics of platelet recovery. Because we've seen platelet recoveries happening at 4 or 5 weeks, like 50, 100, 80,000, which we almost never saw with horse ATG cyclosporin alone. So the addition of eltrombopag to immunosuppressive therapy seems to have changed a little bit the kinetics or the velocity of these responses, and the platelets seem not to be as much of a lagger as they were when we just treated with horse ATG cyclosporin alone. But that's a very interesting observation, and that's something that we always noted. But when you see the other counts improving, like the white lineage, like the leukocytes, and the red lineage, like the red blood cells, it's almost inevitable that the platelet count will eventually recover. It's very unusual to see very good recoveries of these two lineages, and the platelet count really stay way behind. They usually take longer, but they usually catch up with the other counts.
Thank you. Another question regarding eltrombopag. This comes from a patient who was treated with ATG cyclosporin and eltrombopag 1.5 years ago. Did well, but the counts seem to be decreasing. So they're in a watch and wait situation. There's been talk about reintroducing just the eltrombopag. Is there data to support this? And if so, what are their results?
So there is data. So usually when the eltrombopag is given in combination with immunosuppression, as was done in this case. Eltrompeg is discontinued at 6 months, but the cyclosporin in the first dozens of patients was also stopped at 6 months. And what was observed at that point was that the relapse rate with the discontinuation of these two oral agents at 6 months was quite high. So what was done was that the cyclosporin was then continued at a lower dose. Eltrompeg was discontinued. Cyclosporin was continued at a lower dose up to 2 years to prevent relapses. And that's indeed what was observed, is that there were fewer cases of relapses when cyclosporin, instead of being stopped with the Eltrompeg, it was continued at a lower dose, which didn't usually associate with side effects. So I'm not sure if that was done in this case. But having said that, if the person is without cyclosporin and Eltrompeg, you might want to consider putting the patient back on cyclosporin if they're off of it. If they're on it, but they're off Eltrompeg, you might want to consider resuming the Eltrompeg. And what has been seen in these studies is that the majority of patients actually respond to the reintroduction of either cyclosporin if the patient is not on it, or if the patient is on a lower dose, increasing the dose of cyclosporin, or adding Eltrompeg to cyclosporin if the patient is on cyclosporin and is still looking like they're relapsing. So adding Eltrompeg without the cyclosporin can also be done, and responses have been seen there as well. Remember, this has not been systematically studied in hundreds and hundreds of patients. This was done in the context of these clinical trials where some declining counts were observed, and the reintroduction of cyclosporin or Eltrompeg, or both, actually led to the recovery of the blood counts. I have a patient just right now that she's on cyclosporin. We reduced the cyclosporin dose and we stopped the Eltrompeg. Her counts started to go lower. We reintroduced not the full dose 150 7 days a week Eltrompeg, because it was just a mild decrease, but it was a continuous, progressive, gradual decline in counts. We were able actually to stop this decline, and now she's starting to go up on her counts. So these are strategies that can be employed, and in the majority of patients, they tend to work. I mean, of course, there might be a case where the relapse or the declining counts is so profound, so abrupt, and the patients go back on transfusions that even restarting cyclosporin or Eltrompeg or both don't actually give us the results. That's not too common, but it can happen. And then you have to think about a different strategy.
Thank you. This question is, my mom is 82 and was diagnosed just a few weeks ago. Team is not wanting to do ATG, but has suggested cyclosporin and the possibility of adding Eltrompeg. What is the data for using just cyclosporin and Eltrompeg, and would using ATG give a better chance for a response?
Yeah, so that's a great question, because this is something that I have had a lot of interest, because when you look at the algorithms, I mean, the paradigm, right? If you're young, less than 40, and have an HLA sibling compatible donor, transplantation should be offered. If you're older than 40, or you don't have an HLA match sibling, then immunosuppression should be offered with ATG cyclosporin. The problem is that when you start getting to the ages of 60, 70, and 80, cyclosporin can be ATG can be pretty toxic. Now, if you can give ATG, you should give ATG, because there is data coming out of Europe that even in older patients, when you give ATG with cyclosporin and Eltrompeg, the results are better. Now, there's a scenario where ATG might be hard to give given the patient's age, frailty, comorbidities, etc. And then that's where we designed the trial that I just mentioned at the end of my talk, which did the combination of Eltrompeg and cyclosporin without ATG. And and a lot of these patients who actually enrolled in this trial were older patients. This was a global study that included 54 patients in total. And it's interesting because for this older patient who can't get a transplant and cannot get ATG, they're out of an algorithm, right? There's nothing left there for them. So that's one of the reasons we designed that. And it is an active combination. And it's very well tolerated. It's 2 oral agents. It can be given in combination. It's safe. You know, we've established that in context of these studies. It gives you a response rate overall of about 45–50%. Younger patients tend to do better. Older patients tend to have a lesser response, but still can respond to this outpatient regimen, which is well tolerated and has very little in the way of side effects. Of course, if there's a possibility of giving ATG, that's better because the combination of eltrombopag and cyclosporin doesn't seem to give you the same results as when you give ATG combined with cyclosporin and eltrombopag. But again, it has its toxicity, infusion related, and it can be sometimes hard to give in older patients. And a lot of physicians try to shy away from ATG, especially in older patients who have comorbidities due to the risks of serious side effects that can happen with the infusion of the ATG. So if your mom gets eltrombopag cyclosporin, there is data that has been presented at ASH and the European Hematology Association meeting. There's a manuscript we're finalizing right now and ready to submit, which is this 54 patient experience using these 2 oral agents without ATG.
Thank you, Dr. Scheinberg. We have 2 more questions. Our next question is there a preference between, I believe it's pronounced Mepron, MEPRON, and Bactrim for aplastic anemia patients who have had ATG and are waiting for hemoglobin levels to maintain at 8 or greater?
Yeah. So the prophylaxis with that's atovaquone, right? The medication that was just mentioned. So it is an active agent for aplastic anemia. The Bactrim has been used more extensively. I have to say that most of the trials that were done, especially at the NIH, didn't even use Bactrim. They used aerosolized pentamidine monthly, which is a completely different strategy. But outside of NIH, a lot of people have been using Bactrim, usually 2 to 3 times a week, which is a very low dose. I have patients who are on Bactrim twice a week, so it's not a lot. No, because Bactrim can have a little, myelosuppressive effect, so you don't want to keep giving it too much. But if somebody's allergic to Bactrim or sulfa or something that components that are in Bactrim, then atovaquone is the alternative, one of the main alternatives actually to prevent PCP or PCP prophylaxis, because that's what you're trying to prevent here, these opportunistic infections that can happen in these patients. So if somebody cannot tolerate or get Bactrim because of allergy or some other reason, then atovaquone is very well accepted as the effective method of preventing this particular opportunistic infection.
Thank you. This question comes from a spouse. Their husband had ATG, but has only been on cyclosporine. Is there a reason why eltrombopag would not have been introduced? They've been doing treatment for 6 months with no success, and is just curious, maybe what are some of the reasons eltrombopag may not have been introduced?
Well, absolute reasons, I really can't think of any absolute reason. I mean, in adults especially, when you have the combination of the eltrombopag to ATG cyclosporin, in the adults is where you see the greatest benefit, actually, which is kind of interesting. These benefits are not seen as much in the pediatric population or in children, unless, wow, why would you not give? I mean, eltrombopag has liver toxicity, so if somebody but even in patients with cirrhosis who were had hepatitis C in the studies many years ago, were given Eltromapag and tolerated well. So I guess if there's some sensitivity or allergic or something, something to the drug, but that's so rare. It's something that we don't even know before we even give it to patients. So it's very unusual if there's any scenario that you would preclude of giving Eltromapag, at least in the beginning, to try and see how the patients do tolerate it, because there's a 10 to 15% rate of patients who can develop increase in their liver enzymes, but that's usually very well tolerated, and it can go up and it can go down. It's very unusual for it to go really high up, and we have to stop the drug for a few days, and we can re-challenge patients on Eltromapag, and they tend to tolerate too well. But there has been cases of discontinuations, albeit very, very infrequently, due to liver problems or skin rashes or other reasons. So discontinuation after somebody had started on therapy because of side effects, toxicities, there have been few reported cases, but not trying it or not giving it because of some situation, unless the patient expressed these sensitivity or allergic or some kind of allergy to the medication, but from a organ perspective or combination with cyclosporin or ATG, that should not be a reason to not at least try to start it or give it initially with immunosuppression.
And our last question, Dr. Scheinberg, this is about COVID vaccines. So there's actually two questions. One is, this patient was diagnosed with severe aplastic anemia 2 weeks after receiving a COVID vaccine. Their doctor does think that there is a link. Are there studies currently going on to look into this and preserve any data where physicians think that the aplastic anemia was triggered by a COVID vaccine? And second part to that is, do you advise a COVID booster in a patient whose aplastic anemia appeared to develop after a COVID infection?
All right, so these are different but interesting and challenging questions. So for the first one, we've seen cases here as well where patients were diagnosed with aplastic anemia, either after the infection with COVID or a vaccine for COVID. And as I mentioned in my talk, there have been abstracts and some reports at meetings like the EHA and ASH that have, and some publications, but these are all anecdotes and retrospective. And, the UK has published, the United States has published this series of cases that it seems to have some correlation with the infection itself or the vaccine. But again, we have seen this before with viral infections that are not COVID and vaccines that are not for COVID, where you could have the onset of, some hematological diseases like ITP, less so with aplastic anemia, much less well established. But because there were so many patients getting the disease and several people getting vaccinated and a few patients getting aplastic anemia, so this temporal relationship makes one think that there might be an association. It's hard to establish a cause and effect given on what we have in terms of data, but there are registries now that are being established to try to see if the incidence, because the only way we really know if the incidence of aplastic anemia really increased during this period, due to the infections or the vaccinations, and we don't have that data. We have a lot of reports that doctors have, written up for meetings and ASH and EHA and even in publications. So as of now, it's hard to make that 100% statement that there is a cause and effect relationship. Although it might appear that there is in some cases, and I've had a few cases where myself, I question if there might not have been a correlation. But then when I went back to the CDCs before, there was already a bit of an anemia. So was this an ongoing process? And then the vaccination or the infection itself worsened it. It's hard to know. Now about giving a booster, except if you think that somebody had the disease related to the infection or the vaccine, I mean, that's a harder question because we don't know actually what to do. And I have a few patients like this. And I have a few patients who we really think that there could be an association with a vaccine, and a few patients who we think it was associated with the disease, it's the COVID infection, natural infection itself. And what you do after they recover, and I've treated these patients with standard immunosuppression, and many of them have done well. The question is what you do afterwards. And I have to say, it's really a case by case. It really depends on how strongly I believe that there was a cause and effect, and how well the patient recovered and after immunosuppressive therapy, and what is the situation of the pandemic in the region where you are. Because if this patient gets infection again with natural COVID, that's probably not good either. So it's a tough one. These are tough ones, and we don't have a lot of data to actually guide us, other than retrospective anecdotes, which appear to be an association. But obviously, everybody was paying attention to COVID and the vaccination. So anything that happened to patients, aplastic anemia or anything else, there was a natural instinct of actually associating these two things, which might or may not be true. The only way would be, if we have an incidence of aplastic anemia that we know in the United States or in the West, and that tripled or quadrupled. And that would be more harder evidence that in fact there might have been something here as far as a cause and effect, other than just an association where there might be true and unrelated. But these are hard and challenging questions. I'm circling here. I'm not giving you a definitive answer because it's really what we end up doing is a case by case evaluation of that patient.
Thank you so much, Dr. Scheinberg, for sharing your time and your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within just a few business days. If you have any additional questions, please send it to us at any time in 3 ways. You can send an email to help@aamds.org, call us at 800-747-2820, or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you again for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our program. Thank you again, Dr. Scheinberg.
Thank you. Pleasure to be here.